introduce you. It is a pleasure to introduce you to our presenters for today. We will start with Cassie Shan. Sorry about that. So Cassie joined the Guelph Family Health Team, GFHT, in 2018. In her role with GFHT, Cassie supports clients with perinatal mood disorders as the mental health counselor in the Pregnancy and Postpartum Mood Disorder Support Program. Cassie has a Master of Social Work degree from Carleton University and is a driven social worker skilled in crisis intervention, individual and group therapy, and advocacy support. Cassie has continual education certifications in perinatal mental health through Postpartum Support International and is a passionate leader in her role. Next, we have Laura Adam. Laura has been part of the Guelph Family Health Team since 2008. During her time with GFHT, Laura has worn many hats, including diabetes educator and dietitian team lead. For the previous 7 years, Laura has worked in administrative management, holding the title of clinic coordinator. In 2018, Laura became the program manager for the PPMD Program. Laura holds a Master of Science degree through the University of Western Ontario, a certificate in leadership through University of Waterloo, and basic certification in quality and safety through the Institute for Healthcare Improvement. She is passionate about improving access to healthcare. Over her years with the GFHT, Laura has directly influenced the expansion of access to health services for over 17,000 additional community members outside of the Family Health Team umbrella. Without further ado, here are Cassie and Laura.
Great, thank you very much for that warm welcome. Hello everyone, and thanks for attending today's webinar. My name is Laura Adam, and I am the coordinator of the Pregnancy and Postpartum Mood Disorder Support Program. I am also here with Cassie today, who is our mental health counselor with our program, and we're here to talk to you about the implementation of the RNAO's best practice guidelines and how BPSO helped to guide our quality improvement work in our program. Before we get started, I want to make a land acknowledgement. Guelph is situated on treaty land and home to many First Nations, Inuit, and Métis people today. I want to acknowledge the Mississaugas of the Credit First Nation of the Anishinaabe peoples on whose traditional territory our program resides. We have a responsibility to care for and respect the land on which we work. To reflect on my own learnings, I've learned that children are considered a source of joy in Indigenous culture and are valued dearly. I would like to think that our program aligns with these values with the goal of helping parents. Here we go. Here is an overview of what we will be talking about today. First, I will provide a quick snapshot of the Guelph Family Health Team. Next, we will focus on the evolution of the Pregnancy and Postpartum Mood Disorder Support Program, including the implementation of best practice guidelines in perinatal depression. We will talk about our enhanced screening process and the expansion of our program to include prenatal health. Finally, we will show you how we improved access to mental health services for the perinatal population in our community. The Guelph Family Health Team is one of the largest family health teams in Ontario. There are 91 physicians and 4 family health organizations that are part of the Family Health Team. We have approximately 102 Family Health Team staff members of various disciplines that work across and within primary care clinics in the city of Guelph. We operate out of 25 different locations and have 9 different community programs accessible to all residents in Guelph. To give you a better idea of what that looks like, here's a quick snapshot. You can see the PPMD program close to the top here, as well as many of our other community programs. You will also find Diabetes Care Guelph here, and you will notice that we have programs that are both centralized and embedded in our community. So some of the other programs are listed here. I won't go into them today, but you can see them listed here. So let me take you back to 2017. In 2017, the Guelph Family Health Team absorbed the PPMD program, at which time this program was called Postpartum Mood Disorder Program. When we absorbed this program, there were a few inconsistencies. The referral process was not clear. The screening practices varied across the community, including within primary care. The metrics of the program were based mainly on attendance, including the number of appointments attended and number of groups attended. Any feedback was provided mainly through storytelling. The program itself operated 2 days a week, and there was limited knowledge of the program across some community partners. There was also a wait list to get into the program. To give you an idea, the program had an average of about 120 individual appointments in a year, with 1/3 of those appointments being new intakes and about 25 people served in individual support groups. To give you an example of where our quality improvement work started, let me share a story with you. This is a story about Sahar. Sahar was referred to the Diabetes Care Guelph program with gestational diabetes by her midwife at 30 weeks gestation. With no family physician but a need to be closely monitored, she was referred to an OB and came to her first diabetes care appointment upset. Sahar was upset about her new diagnosis of diabetes. She was also upset about the new referral to the OB and what this would mean for her birth plan, and all other stressors in her life seemed to overwhelm her. All in all, Sahar was feeling drained, exhausted, she was unable to sleep, and she had much on her mind. She told her diabetes educator that she was feeling down and was quite emotional during her appointment. Unfortunately, when we look back on this story, we see many missed opportunities. You see, the diabetes educator at the time was not trained in screening for PPMD, and no referral process was in place that was consistent. The clinician did refer Sahar to a community mental health counselor. However, there was a wait time for care. In the meantime, resources were provided like Here 24/7 and the distress line. Unfortunately, at the time, the postpartum mood disorder program was only that for postpartum women in its structure. Therefore, Sahar had no local specialized program to support her during her pregnancy with her mental health. She would have to wait. And this is where the problem was identified to us, and we noticed a gap in care. We asked ourselves, were there other gaps too? Okay, let me see. Oh, I see an error on this slide, but I'll go through it anyways. There's a visual missing here, Andrea. I'm not sure if you can grab it or not, but it's missing on this slide. But there was a nice visual to support our work that we did in our environmental mapping. What I can do is I can send that visual out to you, Andrea, and perhaps you can send it out to the rest of the attendees attending today. So just to give you an idea of our environmental scan that we did in 2019, we met as a team and we came together with all community stakeholders and other team members. Oh, trying to get it there. Okay, I'll continue and I'll continue while you're trying to look for that slide there. There we go, that's it, perfect. So we brought together all of these many different community members to go through an environmental scan on what services were available in our community and outside of our community. We had members of the diabetes care team, we had members of the PPMD team, We had members of our counseling team and psychiatry team. We also had community members from the Guelph Community Health Center and Early On Center in Guelph. Oh, there we go. What we did is we brought everyone together, and with the aim of really walking through Sahar's story. And what we wanted to do was find out all potential points of referral to the program, where these existed across the community and where this could help with care navigation. We came up with 3 realizations pretty quickly. One, that we had a lot of questions. Were people like Sahar being screened for PPMD? Where was this happening and how often? What tools were being used? We simply didn't know the answers to this. Our second realization was that our current program only supported postpartum parents, and there was a gap for prenatal health. And the third realization is that we actually had a lot of work to do ahead of us. Okay, I can go to the, and sorry, just to show you that nice image, that Andrea was showing was an actual screen grab there of the environmental scan that we had conducted with those stakeholders during that 2019 presentation. That was an actual whiteboard grab there. So at the end of the mapping meeting, we decided to come up with a clear, concise program aim. The aim statement that we came up with was, parents are provided with accessible perinatal mental health care when identified with symptoms of PPMD. Parents feel connected, supported, and see improvements in their symptoms of anxiety and depression while receiving care through the PPMD program. This was a great start, but we asked ourselves, how would we know if we were achieving this aim? We knew that we wanted to make a difference in clients' lives. We knew that in order to find out if we were making a difference, we would have to measure. And we would have to measure more than just numbers of appointments. So we asked ourselves, what else did we want to know? How would the program really tell us if we were meeting our aim statement? We immediately knew that we wanted to see an increase in screening for PPMD. We wanted to see an increase in referrals to the program where appropriate. We also knew we wanted to be able to track and measure the care that is delivered. Was the care helpful? Were symptoms improving? Finally, we knew that we wanted to expand care to provide prenatal support and bring better awareness to the community. I'm not sure if you believe in the statement that things happen for a reason, but this was definitely a perfect timing situation. Our organization itself was recognized as a BPSO pre-designate in 2019. And when we absorbed the PPMD program, we knew that there was work to be done. So we made a choice to make perinatal mental health a BPSO priority in 2019 and used BPSO as a tool to help guide us through our change process. I will now pass things over to Cassie, who will walk us through the changes, some of the changes that we performed. Cassie?
Hi, everyone. So we refer to the best practice guidelines in assessment and interventions for perinatal depression, including the ones listed here. We quickly realized that we needed to define routine screening and make communication clear on when screening should happen in accordance with the best practice guidelines. We needed to use a consistent, validated tool as much as possible. We also needed to establish a more consistent referral process to the program when someone does screen positive for PPMD. Another improvement included staff training on PPMD screening for the staff not working directly in the PPMD program. For example, those team members that work with gestational diabetes population like Sahar. Overall, we had this program with amazing potential. However, we needed to make improvements to achieve these best practice guidelines. With the help of the best practice guidelines, so the assessment and interventions for perinatal depression, we set about a goal to increase the number of APDS screens in pregnant women from 50% to 100% across the Guelph Family Health Team. This was a big goal. We decided to start small with our test and screening changes. Based on stories like Sahar's, we decided to test our change in our gestational diabetes population. This population was small, localized to a program, and at a greater risk of PPMD. After many discussions with stakeholders and after reviewing best practice guidelines, we decided to focus on the Edinburgh Postnatal Depression Scale, or the EPDS for short. Although both the EPDS and the PHQ-9 are validated for use in the perinatal population, the EPDS addresses the anxiety components as well as the depressive components and suicidal thoughts. In short, a positive screen for a person at risk of PPMD is a value greater than 9 using this tool. We wanted to improve the knowledge and accessibility of the EPDS screen to clinicians. So we developed, created, and tested an EPDS tool that is now embedded in our TELUS Practice Solutions EMR. This tool allows us to track referral data, is user-friendly, and provides step-by-step support on how to refer to the PPMD program if a person screens higher than 9 on the EPDS tool. Before implementing this tool, we had members of the diabetes care team test the tool. We supported the staff with questions and training on the tool and then spread the training to all staff at the diabetes care clinic that provided care to the gestational diabetes population. So you'll see on this screen here a screenshot of our tool. It's a bit blurry, but if you'd like more information, please feel free to reach out to us after this webinar. Next, we wanted to ensure that support was being accessed when needed. Using the BPSO practice recommendations for assessment, we set about a goal. 90% of those who screen with EPDS scores over 9 for perinatal depressive symptoms are referred to the PPMD program. We also wanted to know that the support provided through the program was working well and helping people. In order to evaluate program outcomes, we wanted to see individual EPDS scores trending down in the program over time, and we wanted to see an increased confidence in support group members over time. I'm happy to say that we're tracking these outcomes right now, although we will not be able to show this data until later this year. And so here's a screenshot of our group evaluation tools. You'll see on the second page is the Edinburgh Postnatal Depression Scale. And the first page is asking questions from group participants about their confidence, their level of support in the group, whether they would recommend the group to others, and so forth.
Thank you, Cassie. So back to me now. As mentioned earlier with our environmental scan, there was a clear gap with prenatal mental health support in the community. We needed to expand our program to provide perinatal support and offer that prenatal mental health support. The expansion of the program would increase program demand, and we simply did not have enough resources. Our team worked on a proposal to request another 1 day a week of mental health counseling resources, or a 0.2 FTE, so to speak. This request would move our program from solely postpartum care to perinatal support, including a mental health wellness class for pregnancy and an anxiety treatment group, which is going to be implemented in the near future. We relied on the BPSO best practice guidelines as a support tool to leverage and support our request for this perinatal approach to care, and for advocating for the needs for the perinatal supports, specifically with the best practice guidelines as a reference. We were successful in securing the additional resources through the submission of a proposal that outlined these best practice guidelines to bring us up to best practice level. I do have to mention that this was only possible through building efficiencies elsewhere in our organization, through attrition and restructuring, and through lots of individuals that specialize in quality improvement work on our team and our fellow BPSO champions in our organization. And as you can see here, our program shifted its name from the Postpartum Mood Disorder Program to the Pregnancy and Postpartum Mood Disorder Support Program. Over the past few years, we have been committed to community outreach. Some of these efforts include community information nights, providing professional development to stakeholders, like teams at the hospital site and the birthing unit, and health promotion through our Wellness Matters class on pregnancy and mental wellness. We have made other on-site changes, including having our program mental health counselor, Cassie, work in a physical accessible space at the Early On Center, where she works alongside another program called the Parent Outreach Program to build better community partnerships between the two programs. Our improvement work is ongoing. Most recently, we found ourselves asking, what is the best way to measure the knowledge of the PPMD program in the community? And we are doing some improvement work right now to track the number of referrals from various community partners. And this gives you a good idea of where we are now. So in summary, we really went from a small, ambitious program with few tracking measures to a more robust program that tracks the work that we do through measurable outcomes. And when I reflect on the past 5 years and the work Cassie and I have done, along with many other team members through our organization, I'm really amazed at the growth and what we've been able to accomplish with the help of the BPSO process. I'll share some data with you now of some preliminary outcomes that we have. You'll see here that this data is reflective of our test group. So as you can see on this chart in front of you, since January 2021, we have used the EPDS tool itself to screen 100% of our test population in the diabetes care program. And those are the women that are coming through the program with gestational diabetes. Our average screening rate for 2020 was 86%, and you can see since the beginning of 2021, there is a shift and a clear indication that 100% of our test population are now receiving the screening tool as our goal, the goal that we set out. So we are really happy to see that come to fruition. Here's another chart here, and here you can find the individuals who screen positive with EPDS scores of greater than 9. And these are the individuals who are referred to the PPMD program. So across the board, you'll see these numbers vary, and that is common. It's what we want to see, but this also shows that we are identifying those individuals who score greater than 9, and we are building in that direct referral to the PPMD program. So we are seeing that care is being directed as needed, when needed. And how is it going now, you ask? Well, if you look at the year of 2021, or 2021, I should say, and yes, we made this change in the middle of a pandemic, and we continued on with our quality improvement change work. We are routinely screening using the validated tool and finding that positive screens are automatically referred to the PPMD program. In 2019, we saw roughly 120 individual appointments. In this last year, we saw 410 individual appointments. We went from 25 people in support group to 34 people in support group. And finally, we now have patient experience data that tells us that 100% of our patients surveyed indicated that they found the PPMD program helpful. And just to wrap things up and move back to Sahar, I would like to share a quote from a program participant. I like to think that with the changes that we've made to the program, I imagine someone in Sahar's situation saying something like this: I attended the postpartum support group. I found it a huge help toward my recovery and the biggest support. The hardest part about postpartum depression is feeling like you are the only one with these feelings and thoughts. The group became the place where I could say anything without fear of judgment and got the support and learned the tools to help me get through my recovery. So we want to thank you for attending today's presentation. Here are both Cassie and myself contact information for you in case you want to reach out after the presentation today. And I think we will be opening up for questions now.
Thank you, Cassie, and thank you, Laura, for your excellent presentation and for sharing the great work that you are doing at Guelph Family Health Team. So you are right, we will be taking some time for questions now. There is a comprehensive list of questions in the chat which highlights the interest in today's webinar topic. The chat has been busy from the beginning. So our first question for either Laura or Cassie, you can answer. So if a woman already has a mental health disorder prior to becoming pregnant, is there any early implementation of this support compared to a woman with no previous history of mental health before conceiving?
I think I can answer that one. So if a client or patient from the Guelph Family Health Team has been diagnosed or struggling with mental health struggles, they are able to see the mental health clinicians that are available at the Family Health Team. So they would be connected with their doctor's office and whichever mental health clinician is available at that practice. A lot of times those mental health clinicians will contact me directly as soon as they find out that the patient is expecting, and we start that transition fairly early on. So if there are any concerns specifically related to prenatal support, they're able to connect with me. So we just kind of transfer the care that way.
Thanks so much. That is actually like a very good segue for the next one, which asks, does this program provide women with follow-up services and community resources when the program is done to give opportunity for future help and support if needed?
Cassie, I think you're probably best to answer that one as well.
No problem. So our program supports parents, caregivers who are in that 18-month period postpartum. So there are lots of opportunities for them to connect after the baby is born, whether it's right away or really anytime during those 18 months. If we find that services are needed after our usual limit, which is about 12 sessions, give or take, or if they need support after the 18 months, they're either connected back to the mental health counselor of their family doctor's office, or if they're not a patient of the Guelph Family Health Team, we'll connect them with community resources. So we'll look into accessing benefits, we'll look into community resources that are available, we'll connect with more expanded programs like the Women's Health Clinic if it's more complex care. So that answer kind of varies depending on the participant's need, but absolutely we would support that, that transition.
Thanks, Cassie. Here's another question. So someone wants to find out how often does this program evaluate its services and implement new research strategies for nurses to utilize?
How often does the program itself? Well, I would say we are constantly completing PDSA cycles and constantly thinking about quality improvement work. Like I said earlier in the community, in the presentation, right now we're thinking about how we can improve knowledge of the community program itself within the community at different points of contact throughout the community. So whether it be through a healthcare provider, such as a primary care office, or whether it be through a community support group embedded in the neighborhood, how can we move forward with improving knowledge of the program? And so to answer that question, I would say to have a formally evaluation, I would say formally evaluated, we look annually at the program, and which includes kind of work that we pull and present to the ministry through our Schedule A, and making sure that our program aligns with our strategic directions of our organization. So annually would be the answer to that more formal evaluation. However, like I mentioned, our quality improvement work is ongoing, and we've really focused at the Guelph Family Health Team to really become a culture of quality improvement over the last few years. So it's really exciting work. It feels like every day there's something to evaluate and look more into. So hope that answers the question.
That's really good to know. So, as what you have alluded to earlier, that your program still continued even in spite of the pandemic, what do you think has contributed to that?
I think, across the family health team, we continue to provide care as needed. Again, we kind of pivoted, as did, I'm sure, everyone. We pivoted and we went through a period of time where we had to organize kind of privacy and confidentiality to shift to a Zoom-based platform to provide group care. During that pivot time where we were figuring out the privacy pieces, what we had done is we had shifted care to virtual visits, virtual and phone visits for a period of a few weeks. And I would say probably about 8 to 10 weeks. And then we pivoted back and were able to provide the support group and the individual care all virtually, including over Zoom. Cassie, do you have anything to add to that?
No, we certainly saw an influx of referrals during the pandemic, mainly because so many moms are feeling that level of isolation to an extremity with the pandemic happening. The only factor that I would say has been really highlighted due to the pandemic is the lack of childcare. And so normally when we run our postpartum groups, we offer childcare to participants so they just have a bit of a break in between. Where they don't have to be on with parenting. And what we've noticed with the pandemic is that has affected group participation, where some moms are struggling to be able to attend as well as child mind at the same time. But beyond that, we've been able to offer that support, like Laura mentioned, through individual care, whether it's phone calls or through virtual platforms. And we've been able to start the postpartum support group last year, and we've been running it every week since.
Thanks so much. You seem to have like an answer for every possible challenge that comes your way, which is great. Here is another question that we are finding in the chat. So it's a lengthy question, but I think it's very important to ask this. Is this support program showing trends in client utilization in the community? And what age bracket do you see them? And then whether they identify culturally and possible socioeconomic standing?
Yeah, so this is a great question, and I would say it's a great question followed up with many other questions. We are looking at trying to better measure exactly what this question is. We're looking at how can we better measure this in the community and really get the information to community support groups, at-risk community support groups in the community, and really start to think about things like how we approach things like language barriers, or in the community, whether or not we are seeing referrals from those community members. So right now, during our pilot, we actually trialed and tested pulling data to show community referrals from primary care physician offices, but we found that the data didn't really give us a clear picture of what we really wanted to see. So it was a really great learning opportunity of, pulling some data and tracking some data that didn't really show us exactly what we wanted to see. So now like I said, we're really looking into how can we work with community partners and how can we measure that better in the community. And that would include, maybe some demographic information of, percentage of populations that we are supporting.
Thank you very much, Laura and Cassie, for that one. It's a very good segue for the next question. So aside from you, Laura and Cassie, what other members of the healthcare team are involved in the program?
Yeah, that's a great question. So we actually had an in-kind part-time public health nurse that was with us for one morning a week, supporting our program, and she was helping to support one of our groups with kind of working in tandem with a mental health counselor. Unfortunately, in March of 2020, that role was taken from us, as public health troops were kind of called to the forefront of the pandemic and redeployed. So we actually lost, during the pandemic, we lost that in-kind service. We haven't had that come back to us yet. So we've had to improvise a little bit, but I think that we were able to really kind of pick up that work. The in-kind public health nurse, like I said, was working in tandem with the mental health counselor. So really what she was doing was running one of the support groups once a week. And that was a morning session. So what we've done, we've all, we switched to this virtual world now. And so Cassie has picked up that work. And I think part of the reason that worked is it was kind of all happening at the same time that we increased some resources as well. I'm hopeful that that in-kind partnership is coming back our way, as we do like to work with, community teams to support the community, but I'm not sure of the timeline for that. And other than the Cassie, who's with our program, and myself, those are, we have a little bit of administrative support as well, with help with referrals, specifically referrals that are not coming through the family health team specifically and outside of the family health team, but that's about it for our resources within the program.
Thanks so much for that. Here is also another interesting question. Does your program just focus on the mother, or can fathers also use these programs?
Yeah, that's a great question. I will pass it over to Cassie to answer that question.
For sure. So we do offer support to dads just as well. There unfortunately is a bit more of a bias. We do see a lot more females and moms in the program than dads. Outside of the pandemic, we had run a caregiver support group. So it was predominantly dads who came in once a month, getting the same kind of support group quality that the moms received. Unfortunately, just with resources available, we've had to put that group on pause. And so what we've offered in the interim is individual counseling or couples counseling when fathers are interested. But really, we do tend to see a lot more moms attending the program than dads, but it's always been available.
Mm-hmm. Thanks for that. So here's another question. So I remember you alluding to doing your consultations over Zoom, and do you find that there's any difference with regards to the participation of the families or your patients? And how do you overcome those barriers?
Well, with respect to Zoom, the child minding piece really does play a big difference. Whereas in person, there are so many moms who attend and they're supporting one another. They're supporting each other's little ones. They're helping kind of bring the little ones back whenever they're wandering around. None of that's available through Zoom. And so we do find that the participation can sometimes wax and wane accordingly. Beyond that, it really is about the fit of the group. And so we try and find timing that works well for moms. We try to find other support group members who are kind of experiencing the same struggles. So there is that level of understanding. And so as long as the fit is right, we do find that the participants tend to share a lot and get a lot of resources, get a lot of validation, get a lot of empathy from the other group members. And that hasn't changed whether in person or through Zoom.
Mm-hmm. So here is a comment from Catherine. So great job in the integration of evidence in creating practice change. How did you navigate this change in practice across multiple settings and with many prenatal care providers? And what were your biggest barriers and facilitators for that?
Yeah, this is a great question. I can really appreciate this question actually, because I find myself right in the depths of this question quite often. Because we have so many different locations, we didn't want to spread a change without first successfully implementing it on a population, a smaller population. We wanted it to be successful. We wanted buy-in. We wanted this change to really improve care and do what we wanted it to do. So what we did is we chose a specific centralized population like that was at risk, like gestational diabetes population, through the diabetes care program. I would say, you know, we successfully implemented it. We're seeing great data. We'll continue to see data and track data around program outcomes, but also the process measurements as well. We are still looking to take what we've done to date and successfully implement it across other multiple settings, across clinic settings. Our next steps with this over the next year will likely be spreading to a couple of smaller clinics. Possibly we're looking at a clinic that has 5 physicians in it, and we have a few members of the team that are really engaged in perinatal care. So we're looking to take the work we've done and spread it now to groups of physicians slowly so that we can implement it successfully and engage and train partners along the way to make sure they feel supported and to make sure that it's done in a way that we see the results like we've seen in Diabetes Care Guelph. If that answers the question. Was there a second part to that?
Yes, there was. What was the biggest barriers and facilitators?
Yeah, so I think one of the biggest barriers, something more to be aware of, is, you know, the drive for change. I mean, we're all passionate about improving care, but I do think the process and the attention to detail along the way is very important, and testing on a small population before trying to implement across the board. So just recognizing that. And I guess that would be a facilitator as well, because once you see the data does support the work and speak for itself. So spreading afterward is a little bit easier once you have a platform from which to kind of jump off into different populations once you have some work done in a pilot population like we did. Other barriers, I would say, you know, one of the things that we mentioned was resources. If we didn't secure those additional resources, I'm not sure what would have happened, but we were very, you know, working with the rest of the team to be mindful of how we could shift some resources to our program, and what that would look like, and, you know, balancing measures across the organization, who would be affected if we did that. So I think we were all engaged in that process, and because of that, it made kind of that barrier come up with opportunities for the program a little bit quicker, just in that we kind of already were engaged with those other members of the team that were involved in some of that restructuring.
Thanks for that. We are supposed to end at 1:45, but there are like a number of questions still in the chat. So if it's okay, can we still like ask you those questions, Laura and Cassie? And for those of you that need to leave, you're welcome to do so. So,
Cassie, I'm fine with staying. Are you?
I'm fine with staying as well.
Thanks so much, Laura and Cassie. So the next question is, speaking of public health, was it a duplication of their services that they provide to new mothers, or did you work together as there is a lot of crossover?
That's a great question. And actually, it's pretty, it falls in line with a lot of these, when these changes happens. Actually, I would say right during 2019, we engaged with public health. Public health wanted to, they were looking at all of their programs and evaluating, you know, where work was done, and wanted to ensure that services were not duplicated. So public health actually approached us to do an evaluation of the resources that they were providing to us in kind. And that evaluation took, I would say, approximately 2 weeks, lots of questions. And again, we were on the same page. We want to make sure that we're providing the best care in the community and we're not duplicating services. So at the end of that evaluation, they found that services were not being duplicated, and that, that there was a need and there wasn't any overlap there. So the services that the public health provided in kind were continued, because at the end of the day, the public health nurse was providing a very specific role, helping our mental health counselors in a mental health group. It wasn't a public health nursing role. It was a specific role that was being played in the PPMD program.
The next question is, how is the program introduced to the women? As I know, if they are not aware of their depressed mood, they won't seek help. This came from like a participant.
Yeah, this is also a great question. So we found that, and again, like I had mentioned earlier, we are doing our own, we're always testing new things and we're evaluating how things are working. So after about 2 months, if you go back, can I go back to that graph? The first graph that I showed, if you can go back to that graph, and I can use that graph to kind of help the RNAO graph. Not sure if I can, can I control? Yes. Oh, here we go. Okay, perfect, sorry. Okay, let me go back here. Okay, so if you can see from about September to January, the numbers were not at the 100% screen. So what we found, we have in about November, I would say, of 2020, we approached the diabetes care team and we asked for feedback. We said, how are things going? How can we help to assist, in any areas that you're having? And some of the team members had said to us, exactly that, women and parents, coming through the program, were asking questions, why the team wanted to ask about PPMD. And they found, depending on different health clinicians, they found that there was inconsistencies in how they described screening for PPMD. So we decided to put together a little bit of a script for them that they could use to talk about the PPMD screen and to talk about the benefits of screening, why it happens, what to expect, how often. And we developed a handout with that information on it. And we put it in a package that all of the participants or the women who are coming through the gestational diabetes program, we actually put it in that package that they receive on their first day. And ever since we put that in the package, the clinicians said to us a few weeks later that this was helping. It was, really helping to guide the conversation and support them opening up the EPDS screen tool as kind of an icebreaker, because instead of getting to the EPDS tool and asking the questions, we are now talking about the importance of screening for PPMD at the beginning of the care provided as part of kind of normal care. And it opened the conversation up a lot more easily with that. So we think that that's one of the contributing factors that led to the trend that you see from Jan until current. We like to think that that's one of the contributing factors, but that's a great question. It's something that we came against.
Thank you very much, Laura and Cassie, for spending time and sharing all these wonderful information and nuggets of wisdom with us. Time just flew, and the time we have for this webinar has come to an end. We want to thank everyone for taking time out from their day to take part in this webinar. and for all your thoughtful questions. Again, thank you, Laura and Cassie, for answering the questions. For the participants, you will soon receive a link to an online survey to evaluate today's presentation. Please let us know of any suggested topics you would like us to work on. And immediately after you have done the evaluation, you will receive your certificate of attendance. Again, thank you very much for joining us today and wishing all of you a great afternoon. Bye, everyone.
Thank you.
Thank you.